Hello, learners. Welcome to Lecture 32 of this course, where we will focus on common childhood illnesses and their wider social implications. Building on our last discussion on growth and developmental milestones, today we shift our attention to the conditions that often interrupt this progress. Childhood illnesses are not just medical concerns, but have far reaching impact on families, communities, and societies. Now, understanding both the clinical aspects and the social dimensions equips us to design comprehensive interventions that safeguard child health and welfare. Childhood illnesses remain a pressing public health challenge, particularly in low and middle income countries where they contribute significantly to morbidity and mortality. Conditions like diarrhea, pneumonia, malaria, and malnutrition disproportionately affect vulnerable populations. However, the impact extends beyond physical health, straining household resources, disrupting education, and perpetuating cycles of poverty. Recognizing the dual medical and social dimensions of these illnesses is essential for designing effective holistic responses. The most prevalent childhood illnesses include diarrheal diseases, respiratory infections such as pneumonia, malaria in endemic regions, and a range of vaccine preventable conditions like measles and pertussis. Malnutrition, while often considered a separate issue, both contribute to and results from recurrent illnesses. These conditions are responsible for a proportion of under 5 mortality worldwide. Addressing them requires preventive, curative, and rehabilitative measures supported by strong health systems. Priority actions include prevention through full immunization, exclusive breastfeeding for 6 months, vitamin A supplementation, deworming, safe water sanitation hygiene, insecticide treated nets, and indoor residual spraying where malaria is endemic. For diarrhea, early oral rehydration salts with zinc prevents deaths and speeds recovery. Avoids unnecessary antibiotics. Suspected pneumonia needs prompt assessment of danger signs. Malaria control relies on rapid diagnostic tests. Management of malnutrition concurrently for screening of height, weight, ready to use therapeutic food for severe acute malnutrition and linked social protection to prevent relapse. Community health workers anchors home, follow up, caregiver counseling, and timely referral, while primary health centers ensure uninterrupted supplies of ORS, zinc, antibiotics, antimalarials, and oxygen. District dashboards, death audits, and outreach to high risk pockets close equity gaps so prevention and treatment reaches every child. Diarrheal diseases are among the leading killers of under 5, particularly in regions with poor sanitation and unsafe drinking water. Frequent episodes lead to dehydration, malnutrition, and in severe cases, death. The tragedy is that diarrhea is largely preventable through safe water sanitation and hygiene practices. Oral rehydration solutions and zinc therapy are simple, life saving interventions. Yet, lack of access and awareness perpetuate high mortality rates. Acute respiratory infections, especially pneumonia, remain a major cause of child mortality. Malnutrition and indoor air pollution from solid fuels increases vulnerability. Children in overcrowded households face additional risks. Timely diagnosis and antibiotic treatment can save lives. Yet, many children do not receive prompt care due to barriers in access and cost. Prevention through immunization and improved living conditions is equally vital in reducing the burden. Malaria continues to be a serious threat in tropical regions. Young children with their underdeveloped immunity are especially vulnerable to several forms. Symptoms like fever and anemia not only cause illnesses but also impair cognitive and physical development. Prevention through insecticide treated nets, indoor spraying, and vector control remains crucial. Access to early diagnosis and treatment with effective antimalarials reduces fatality, but health system gaps often limit coverage. Vaccine preventable diseases once caused widespread childhood deaths, but have declined significantly thanks to immunization programs. However, measles, pertussis, and diphtheria continue to appear where vaccination coverage is incomplete or low. Though eradicated, remains a reminder of how quickly diseases resurface is if vigilance drops. Ensuring universal immunization is a cornerstone of child health, but barriers such as misinformation, logistics, and inequities keep some children unprotected. To close these gaps, programs should zero in on zero dose and under immunized using due lists, door to door verification, and target outreach in urban slums, migrant work sites, and remote hamlets. Strong micro planning for village health sanitation and nutrition days. Cold chain monitoring with electronic vaccine intelligence network. Data loggers and contingency transport reduce session cancellations and stockouts. Risk communication must counter misinformation and trusted messengers. Ashas, religious leaders, teachers, and simple, culturally resonant messages about safety and benefits. Catch up campaigns and supplementary immunization activities should be scheduled after outbreaks or surface disruptions to restore herd immunity quickly. Adverse event following immunization preparedness, trained staff, emergency kits, clear referral pathways builds community confidence and prevents panic. Real time dashboards that disaggregate coverage by gender, caste, tribe, and settlement type help districts focus on equity, not just averages. Finally, tight integration with nutrition, deworming, and primary care ensures every contact counts, turning routine services into reliable protection for every child. Malnutrition is intricately linked with childhood illnesses. Undernourished children have weaker immune systems, making them more susceptible to illnesses and infections. In turn, frequent illness worsens nutrition status, creating a vicious cycle of infection, malnutrition. So, malnutrition contributes to nearly half of under 5 deaths globally. Addressing this requires not only food security, but also interventions targeting hygiene, infection control, and maternal education, ensuring that children thrive in both health and nutrition. Beyond underweight, remember the spectrum wasting, stunting, and hidden hunger from micronutrient deficiencies. Illness worsens nutrition through reduced intake, malabsorption, and parasitic losses. The first 1,000 days from contraception to 2 years is a critical window when growth faltering and neurodevelopmental losses can still be prevented. Core actions include exclusive breastfeeding for 6 months, diverse complementary feeding with animal source foods where feasible, and responsive feeding to maintain intake during and after illness. Routine scans with mid-arm circumference and weight for height manage moderate acute malnutrition with nutrition counseling and supplements, and severe acute malnutrition with ready to use therapeutic food and facility care when complicated. Pair nutrition with water, sanitation, hygiene, deworming, zinc supplements, oral rehydration salts for diarrhea, and vitamin supplementation to break the infection malnutrition loop. Support maternal nutrition, iron, folic acid, calcium, diversified diets, and delay adolescent pregnancy to protect fetal and infant growth. Deliver this package through ICDS services, village health, sanitation and nutrition days, home based care for young children, and social protection, ensuring that poorest households are reached first and nobody is left in the vulnerable populations. Beyond the major killers, children are frequent, as beyond the major killers, children also frequently suffer from conditions like skin infections, scabies, and intestinal worms. These illnesses may not be fatal, but they cause discomfort, stigma, and chronic ill health. Intestinal worms and anemia contribute to poor school performance and reduced productivity later in life. Such conditions highlight the importance of comprehensive child health strategies that go beyond mortality reduction to address well being. The burden of childhood illness is heaviest in low income settings, where health systems are weak and social determinants create additional risks. Poor families bear the brunt, as illness exacerbates financial strain through treatment costs and lost income. Children from disadvantaged households are more likely to die or suffer complications. This reflects broader inequities in health access, making childhood illnesses both a health and social justice issue. Childhood illnesses disrupt education significantly. Frequent illnesses leads to absenteeism, causing children to fall behind in learning. Even when present, children may perform poorly due to fatigue, anemia, or lingering effects of infections. Chronic illnesses undermines concentration and academic achievement, limiting future opportunities. Thus, investing in child health is also an investment in education and human capital. When children fall ill, families experience both financial and emotional stress. Treatment costs can push poor households into debt. Parents may miss work, disrupting livelihoods. Emotionally, caring for a sick child causes anxiety and tension in the families. Siblings may take on additional responsibilities, altering family dynamics. Illnesses in children therefore affects entire households, not just the individual child. The gender dimension of childhood illness is significant. Mothers, as primary caregivers, bear the brunt of caring responsibilities, often at the cost of their own health or economic opportunities. In some cultures, boys are prioritized for treatment, while girls may be neglected. Gendered access to health services perpetuates inequality and undermines girls' survival chances. Addressing child health must therefore incorporate gender sensitive approaches. Some childhood illnesses, such as HIV, skin conditions, or disabilities, carry stigma within communities. Affected children may face isolation, bullying, or exclusion from education. Parents may hide illness due to shame, delaying treatment. Stigma becomes a barrier not only to care seeking but also to social inclusion. Overcoming stigma requires awareness campaigns, community dialogue, and policies protecting the rights of affected children. Illnesses in children often drives families further into poverty through healthcare costs and lost income and out of pocket expenditures. This creates a vicious cycle where poverty increases vulnerability to illness and illness reinforces poverty. Malnourished or uneducated children grow into adults with limited opportunities, perpetuating intergenerational deprivation. Breaking this cycle requires integrated health, social, and economic interventions that address root causes alongside medical treatment. Health systems face numerous challenges in addressing childhood illnesses. Inadequate infrastructure, particularly in rural areas, limits access to care. Shortages of trained staff hinder timely diagnosis and treatment. Unequal access to essential medicines and vaccines further compounds disparities. Strengthening these health systems through investment, training, and equity focused policies is vital to reduce the burden of childhood illnesses and its social consequences. The integrated management of childhood illnesses strategy by WHO and UNICEF provides a framework for tackling common illnesses. It focuses on holistic management rather than disease specific approaches. IMCI emphasizes case management, health system strengthening, and community practices, integrating prevention and treatment. This strategy has proven effective in reducing under 5 mortality when implemented properly, highlighting the importance of comprehensive integrated care. Immunization remains one of the most cost effective interventions in child health. It prevents deadly diseases such as measles, diphtheria, pertussis, reducing morbidity and mortality. Widespread immunization also provides community protection through herd immunity. Gaps in coverage, however, allow outbreaks to persist. Ensuring equitable access to vaccines is a critical strategy in reducing common childhood illnesses and their wider social burden. Good nutrition is both preventive and curative in childhood illnesses. Adequate nutrition reduces the risk of infections and supports recovery when illness occurs. Malnourished children are more likely to suffer complications and die. Nutrition interventions such as exclusive breastfeeding, complementary feeding, and micronutrient supplementation are essential components of child health strategies. They not only improve survival but also enhance cognitive and social development in children. Community based interventions are crucial in addressing childhood illnesses. Promoting oral rehydration, salts used for diarrhea, teaching home based care for mild respiratory infections, and providing health education empower families to act promptly, especially before they reach the facility. Community health workers like the accredited social health activist ASHA and A&M build trust through home visits and village health sanitation and nutrition days, demonstrating correct ORS zinc preparation, hand washing, and safe feeding during illnesses. Using integrated management of neonatal and childhood illnesses, job aids, they coach caregivers to spot danger signs, fast breathing, chest indrawing, persistent vomiting, lethargy, convulsions, and trigger early referral via ambulances. Home based newborn care and home based care for young children provide follow up for pneumonia, diarrhea, and malnutrition. With mid arm circumference screening, deworming, vitamin A supplementation, and immunization checks. Simple tools such as mother and child protection cards, short message service reminders, and clean water kits help families adhere to treatment and return to follow up. Community scorecards and mothers groups tackle bottlenecks, while social and behavior change communication counters misinformation about antibiotics and vaccines. By equipping communities with knowledge and low cost tools, many childhood deaths can be prevented outside formal health facilities, while timely referrals ensure that severe cases reach oxygen, antibiotics, or inpatient care without delay. Schools are not just educational institutions but also platforms for health promotion. Teachers can educate children about hygiene, nutrition, and disease prevention. They can also identify sick children early and refer them for care. Supporting reintegration of children after illnesses prevents stigma and ensures continuity of education. Schools thus serve as key allies in preventing and mitigating the impact of childhood illnesses. Families are the first responders when a child falls ill. The decisions about care seeking, treatment adherence, and preventive practices are shaped by their culture, beliefs, knowledge, and resources. Families play a crucial role in ensuring nutrition, hygiene, and early medical care. Strengthening the family capacity through education and support is essential for reducing the burden of childhood illnesses and their social implications. Media and communication strategies, as we discussed in the last lecture, are powerful in promoting RCH awareness. In the context of childhood illnesses, they raise awareness about preventive practices, address myths about treatment, and promote timely care seeking. Campaigns on ORS use, immunization, or hygiene practices have shown a strong impact. Media serves as a bridge between health systems and communities, amplifying health messages for widespread adoption. Childhood illnesses disproportionately affects marginalized groups such as rural communities, slum dwellers, and tribal populations. Bridging these inequities requires targeted interventions that improve access to care and affordability. Mobile clinics, subsidies, and community outreach can ensure that no child is left behind. Addressing inequities is not only a moral imperative but also essential for reducing overall burden of disease. Policy and governance shapes the response to childhood illnesses. National child health programs set priorities and allocate resources. Adequate funding for universal health coverage ensures that children access care without financial hardships. Monitoring and accountability mechanisms track progress and highlight gaps. Political will and good governance are indispensable for reducing child morbidity and mortality and addressing their social implications. Child health is fundamentally a matter of rights. Children have the right to health and access to essential services. Ethical considerations demand equity and justice in the distribution of resources. Even in pediatric care, informed consent and dignity must be respected, involving families in decisions. Ethical frameworks guide health professionals in delivering care that is not only effective but also humane. Future challenges which will shape the burden of childhood illnesses in new ways. Emerging infections like COVID 19 highlight the vulnerability of children to pandemics. Climate change increases the risk of vector borne diseases, malnutrition, and displacement. The digital divide limits access to health information, widening inequities. Addressing these challenges requires adaptive, resilient health systems and integrated strategies that protect children in changing environments. To summarize, childhood illnesses such as diarrhea, pneumonia, and malnutrition remain leading cause of morbidity and mortality in children. Yet they are largely preventable and treatable with existing knowledge and resources. Their social implications from education disruption to poverty and stigma amplify their impact. Effective responses must be integrated, community based, and equity focused, ensuring that every child has a chance to survive and thrive. In conclusion, childhood illnesses are not simply biomedical conditions but social issues that shape families, communities, and future generations. They demand comprehensive action that combines medical care with education, social protection, and policy reform. Protecting children from illnesses is central to achieving health equity, human development, and national progress. This recognition should guide our practice as health professionals and policymakers. As we close this lecture, let us reflect on the idea that healthy children form the very foundation of a healthy society. Illnesses in childhood leave scars that extend beyond the individual, affecting families and entire communities. By preventing and managing childhood illnesses effectively, we invest not only in the lives of children but also in the future of nations. Our challenge is to translate this vision into sustained, equitable action. So, this is all in this lecture. Next, we'll take up lecture 33, which deals with child immunization and vaccine preventable diseases. Thank you.